So at the end of the day, could we say that at least, even if we are not able to show an added effect on disability progression, that we have an oral anti-CD20?
I think that's a really good way to think about the results of these trials, Ludwig. And, we're always told we're not supposed to compare across clinical trials, but when you actually look at the magnitude of reduction of annualized relapse rate of fenebrutinib in comparison to teriflunomide, it really does raise, it looks very similar to what we've seen with many of the anti-CD20 agents. Hi, everyone. I'm Jiwon Oh. I'm a neurologist at St. Michael's Hospital at the University of Toronto.
Hello, everybody. My name is Ludwig Kappos. I'm a neurologist based in Basel, Switzerland, with a special interest in MS and in clinical trials in MS and assessing the disease course.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. This episode is part of our ongoing series bringing you the very latest developments in MS research, and today's conversation is truly hot off the press. Earlier in the year, we explored the full clinical trial results for fenebrutinib in people living with progressive MS, following its presentation at the ACTRIMS Forum. That gave us an important first look at how this treatment might perform in a progressive disease setting. However, fenebrutinib belongs to a newer class of therapies called BTK inhibitors, or BTKIs, a group of treatments generating real interest because of their potential to impact both the underlying biology that drives progression and relapsing inflammatory activity. Having seen from the initial press release that a separate trial in relapsing MS had also been successful, we were excited to see what the data from this trial had actually shown. And right now we're recording fresh from the AAN conference, where the results from that relapsing MS trial have just been presented in detail for the first time. In this episode, I'm joined by two of the trial leads, Jiwon and Ludwig, and together we'll unpack what was presented, what the results actually show, and what this could mean for the future treatment landscape in MS. Let's get into it. Jiwon, Ludwig, thanks for joining me.
Thanks for having us.
Yeah, thank you for having us. And let's start with the discussion. Jiwon, would you want to summarize why these two trials were conducted?
Sure. So I think everybody has heard a lot about BTK inhibitors in the last few years. So many of different BTK inhibitors are almost simultaneously being studied in MS, and we've already heard the results of other BTK inhibitors. But what's really exciting is that very recently, fenebrutinib was evaluated in both primary progressive MS and now in relapsing MS. And in relapsing MS, fenebrutinib was evaluated in FENhance 1 and 2, which were two nearly identical phase 3 clinical trials that looked at the efficacy and safety of fenebrutinib in people with relapsing MS and compared it to teriflunomide, which is a very commonly used first-line disease-modifying treatment in relapsing MS. So in these two nearly identical trials in a pretty typical population of very early relapsing MS patients, excitingly, fenebrutinib did show an effect on the primary endpoint, which was annualized relapse rate. So people in these two trials who are treated with fenebrutinib showed a substantial reduction in annualized relapse rate of 51 to 59% in FENhance 1 and 2 in comparison to teriflunomide. So this is really exciting because we've heard the results of a number of other BTK inhibitor clinical trials in relapsing MS, and they actually failed to meet the primary endpoint of showing a reduction in annualized relapse rate. But in FENhance 1 and 2, fenebrutinib very clearly reduced annualized relapse rate versus the active comparator of teriflunomide.
So if I can just jump in, obviously, great to have such good conversation between the two of you. Just to jump back with this a little bit before we go too far down the road with the FENhance trial results, I'm interested in hearing a little bit of putting this into context with what had been seen previously from the FENopta phase 2 trial that was published in late 2025 in The Lancet.
What we see in FENhance 1 and 2 with fenebrutinib very clearly demonstrating a substantial reduction in annualized relapse rate versus teriflunomide is not necessarily surprising given what we observed in FENopta. So just by way of reminder, FENopta was the pivotal phase 2 clinical trial that evaluated fenebrutinib versus placebo, initially over a 12-week period. And it looked at the effect of fenebrutinib on the primary outcome of new gadolinium-enhancing lesions. So in that trial, fenebrutinib very clearly showed a substantial reduction in GAD lesions starting at week 8. And when you look at how substantial that reduction was, it was a near suppression of GAD-enhancing lesions, and that was sustained throughout the 96-week duration of the study. And I should say the 96-week duration was the extension period of the study, but it really showed a profound reduction. And so the expectation would be that fenebrutinib is a drug that has a profound effect on relapsing disease biology. So the fact that it very clearly in FENhance 1 and 2 reduced annualized relapse rate, which is the clinical endpoint that reflects relapsing disease activity, is not necessarily surprising. But as we talked about earlier, I think based on results of recent phase 3 BTKI trials of other BTK inhibitors, it is kind of a relief that this was seen.
Yeah, I think we agree that FENopta was the phase 2 study with a BTK inhibitor that has shown the most convincing effect on acute inflammatory activity, of course with the primary endpoint, but also with an effect on relapses over a period of 1 or 2 years. So this was certainly raised expectations regarding this outcome. On the other side, we want to see if this effect compares in some way well with other drugs, something that was not done in the phase 2 study, which was against placebo. And of course, using the similar design or capitalizing on the similar design that this study has with 2 other large relapsing MS programs with 2 other BTK inhibitors to see how it compares with these drugs. And I think that's the key question. And perhaps we can recapitulate the design of the studies that we are discussing now and are presented here. FENhance 1 and 2 are 2 parallel studies where fenebrutinib is given twice daily as compared to teriflunomide, the approved dose. And patients are a typical relapsing remitting population on one side, and on the other side followed also in a similar fashion as in the other studies for 2 years. The primary outcome was relapse rate, and then key secondary outcomes were effect on acute lesions in MRI, and also then any effect that could be shown on a disability change over time, be it to the better or to the worse, and this based on a composite endpoint where not only the EDSS was used, but as the most important outcome or disability outcome, a combination of the EDSS with a 25-foot walk test and 9-hole peg test.
And so we've, I think, already covered some of the outcomes related to the primary endpoint with the annualized relapse rate. I'm interested in delving into some of the data that you saw from some of those secondary endpoints that Ludwig's just described. Jiwon, do you mind running us through what analysis you've seen there?
Sure. Just to summarize, as we've talked about, the annualized relapse rate was significantly reduced in FENhance 1 and 2 by 51 to 59% in FENhance 1 and 2 respectively. And then with respect to the MRI endpoints, as expected, T1 gadolinium enhancing lesions were reduced by 71 to 78% in FENhance 1 and 2 respectively. And again, as expected, when we look at new and enlarging T2 lesions, fenebrutinib reduced these by 76 and 83% in FENhance 1 and 2 in comparison to teriflunomide respectively. So the clinical primary endpoint of annualized relapse rate and the key secondary MRI endpoints all went hand in hand in demonstrating that phenibrutinib very clearly reduces these various measures of relapsing disease activity in comparison to teriflunomide.
Ludwig, is there anything you want to add on to the analysis of those results?
Yeah, I think this is quite nicely summarized. The problem that we encounter with very pronounced effects on acute disease activity, at least on those measures that reflect, in the majority opinion, acute disease activity, that these make it more difficult to discern the effect that is the most, needed, and where such a compound would answer unmet need, which is effects on more diffuse activity, on what we understand as neurodegeneration, and on progression of disability. So this makes it more difficult for us and to understand that. And Siobhan, what is your take of the data that have been now presented regarding effects on composite endpoint and individual endpoints?
So you already said, Ludwig, the key disability endpoints were composite confirmed disability progression, and there was not a clear significant effect of phenibrutinib in diminishing CCDP versus teriflunomide. However, when you look at the numbers, almost all of these disability endpoints consistently showed a trend towards phenibrutinib diminishing various measures of disability in comparison to teriflunomide. It's disappointing that very clearly it wasn't a slam dunk in terms of significantly showing an effect. However, I think we're at a time in MS where in clinical trial settings where we know that the contemporary clinical trial MS population has changed in comparison to clinical trial populations from decades ago. And because people who are recruited into relapsing MS clinical trials tend to be very, very early in their disease course, have very minimal disability to begin with, sometimes it is difficult to very clearly, in the duration of a clinical trial setting, detect an effect on diminishing disability progression, even if there is one. So I think the fact that, these disability endpoints all consistently at least showed a trend towards benefiting suggests that there probably is a benefit, but it is disappointing that it wasn't a, slam dunk statistically significant difference. What about you, Ludwig? What are your thoughts?
Of course, agree with the overall statement. I think it shows also that the trial methodology that has helped us to establish all the currently available treatments, treatment modalities and compounds has come to impasse. So it is not really adequate, not really adapted to the needs nowadays. This dilemma to separate between an effect on acute disease activity that overlays another effect on disability progression and makes it very difficult to assess its existence in some way. In the strict statistical position of significance, you would say we failed with these two trials. On the other side, also to quantify that, so to assess the magnitude of the effect. And this, so for that, I think we need to agree to another approach and make more realistic expectation, or define more realistic expectations and define also our outcomes accordingly. I think that's the key message from these studies. The jury is still out regarding anti-degenerative or additional value as compared to pure suppression of acute disease activity. but I think it will take some time and some very thorough consideration, retrospectively, and perhaps also additional prospective trials to support that and to gather convincing arguments for this added value. One argument that for me is interesting here is within the composite CDP or confirmed disease progression, that on one side the pooled analysis that was unfortunately not foreseen for the primary analysis of the two studies at the end of the day has a significant advantage to teriflunomide, and also that one of those tests in this composite that are perhaps most complementary to the EDSS, which is the 9-hole peg test, that this again went into the right direction. So I think these two signals enhance make me a little bit more optimistic regarding outcome of this ongoing assessment.
So just picking up on one of the interesting points there around cohorts and potentially having people who are earlier in their disease and a little bit younger, I thought one of the interesting pieces of data that came out of this was some of your predefined subgroup analysis, where you saw potentially a different treatment effect based on age. Do you want to talk us through what those results showed?
Sure. So, I mean, these results are not necessarily surprising, but when we looked at different subgroups where people were stratified by age, as well as time since symptom onset, baseline EDSS score, and whether or not they had baseline T1 gadolinium enhancing lesions, fenebrutinib seems to have a more profound effect in comparison to teriflunomide in people who were younger, who were more recently diagnosed, and in people who had lower baseline disability status scale scores, as well as those who had GAD-enhancing lesions at baseline. So, very clearly, fenebrutinib has an effect across the spectrum of patients that were evaluated in FENhance 1 and 2, but fenebrutinib does seem to have a greater effect in people who are younger and essentially have more evidence of relapsing disease activity from the beginning.
So at the end of the day, could we say that at least, even if we are not able to show an added effect on disability progression, that we have an oral anti-CD20?
I think that's a really good way to think about the results of these trials, Ludwig. We're always told we're not supposed to compare across clinical trials, but when you actually look at the magnitude of reduction of annualized relapse rate of fenebrutinib in comparison to teriflunomide, it really does it looks very similar to what we've seen with many of the anti-CD20 agents. So in a way, at least based on the results that we see right now, based on what we see with the relapsing disease activity measure reductions, it does seem that fenebrutinib does seem to perform similarly. So is kind of an oral option as a high efficacy agent against relapsing disease activity.
So I think clearly we've got some really interesting results here around the efficacy of fenebrutinib. I think it's important in any trial, but particularly in some of these BTKI trials where we've seen some safety concerns previously. Ludwig, I don't know if you want to start us with this. What sort of safety profile did you see in the FENhance 1 and FENhance 2 trials?
Well, I think it is quite reassuring in the overview of the data in these two big studies, large studies, that the adverse event profile did not really differ from that of teriflunomide. So overall, both the rate of infections and the number of serious adverse events were very similar within the variability that you would expect in any study of this size. So the concerns, or the initial concerns were regarding hepatotoxicity. And again, here what emerges is much less of that. There is a higher number of liver enzyme elevations, but at the end of the day, in the overview, there is no real difference between the two compounds. As we know, also teriflunomide has a certain hepatotoxicity, so there as an approved drug, so there is no difference that would make you anxious or increase anxiety regarding this effect that was supposed to be a class effect of BTK inhibitors, but in this case seems to be at least less visible in the setting of this relapsing MS study.
I think it's worth just touching upon briefly because obviously it was noted in the presentation there was an imbalance in deaths between the two groups. I think if we can just have a quick comment on that just to note where that had come from or if there are any concerns associated with that.
Sure, Brett. So obviously safety is extremely important, and there was an imbalance in the number of deaths across the FENhance clinical trials. When you look at deaths in fenebrutinib versus teriflunomide, there were a total of 7 deaths in the fenebrutinib treatment arms, and there was a single death in the teriflunomide treatment arms. So obviously when there is a larger number of fatalities, this needs to be taken very seriously, and these deaths need to be individually evaluated. The good news is when you look at the 7 deaths that were observed in the fenebrutinib treatment arms, there wasn't any clustering of a specific cause, particularly a cause relevant to the mechanism of action of fenebrutinib, which is reassuring. Of the 7 deaths, 2 of them were infections and deemed by study investigators to be likely related to the drug. However, there were a number of contributing factors in each of these infectious deaths. One of the deaths was related to pneumonia, but this was a patient where actually the family refused hospitalization. And so obviously that was probably a complicating factor resulting in the fatality. And then another death related to infection was from neurocryptococcosis in a region where this is a bug that is endemic to the region and can even become infectious in an immunocompetent host. And so this was unfortunately the other death. But the bottom line is obviously these cases are being taken very seriously, and safety will need to continue to be monitored should fenebrutinib become available for use in the real world. However, again, it is reassuring that there really wasn't any sort of clustering particularly relevant to the mechanism of action of fenebrutinib that raises serious red flags.
So I guess coming out, we've seen the results now. Moving on to what you think are the next steps for fenebrutinib in a relapsing cohort. What are your thoughts in terms of if this will be approved for a relapsing cohort? And obviously that's a difficult question to answer, but if so, where do you see it fitting into the existing treatment paradigm? And as a last question, when can we expect the full results of the trial to get published? Because obviously this one is not yet available. I don't know who wants to start with that. Maybe Jiwon.
Well, I'll start with the easy question first, Brett, in terms of when to expect publication. Now that the results of FENhance 1 and 2 have officially been reported, that is being worked on right now. And so the hope is, really within the next couple months, hopefully there will be a full publication outlining all of the results of FENhance 1 and 2. In terms of the more challenging question of where do we see this fitting in the treatment paradigm? Well, first, I think we need to take a close look at all of the results once they're available. Given what we've seen with the results of FENtrepid, where fenebrutinib was clearly non-inferior to ocrelizumab, and actually when you look at the benefit of fenebrutinib versus ocrelizumab, the magnitude of the benefit was greater than ocrelizumab throughout the duration of FENtrepid. So we know this already. And given what we're seeing in FENhance 1 and 2, where clearly this is an agent with high efficacy against relapsing disease activity, so long as the safety profile pans out, I think this is a drug that will have potential across really the spectrum of MS. Because, as Ludwig alluded to earlier, this is a drug that is behaving kind of like our highest efficacy agent that we have right now for relapsing MS, which are anti-CD20 monoclonal antibodies. Given what we see in the relapsing MS trials and that we have seen that it is clearly non-inferior to ocrelizumab, which is the only agent we currently have for PPMS, so long as the safety profile pans out, it probably is a nice oral option that is a relevant, efficacious option across the entire spectrum of MS.
Yeah, I also agree. I think the profile that emerged out of these 3 phase 3 studies supports a broad indication in MS, unless something appears from the safety that up to now has not emerged, although we have looked quite thoroughly to that. So in this regard, I'm quite confident that this can be approved. You always don't know when, but I think the arguments for approval based on the current evidence are very strong.
We look forward to seeing the full results. We look forward to seeing what the future is of this therapy and hopefully another option for people living with MS. I want to thank you both, Jiwon and Ludwig, for your time today, sharing your insights into this really exciting and new trial. And thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MS Translate. The ECTRIMS podcast is produced and hosted in collaboration with 2 key partners, MS Translate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community, and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2025-26 ECTRIMS podcast series is supported by educational grants from Alexion AstraZeneca Rare Diseases, Bristol Myers Squibb, Roche, Sanofi, and UCB. Educational grant providers have no input in the podcast content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels, including Apple and Spotify, and follow ECTRIMS on X, LinkedIn, Facebook, and YouTube.